And we also have Dr. Moses Alobo from Lignum Vitae Health. And we want to thank Lignum Vitae for sponsoring this CME today. And I'm sure we are going to learn a lot and what we can do to help our patients. So I will not take too much time. I will give the floor to Dr. Owende. And please, I'm sure there will be questions, there will be comments. Feel free to post them on the chat, and we will take them up later on once we have finished the presentation. Thank you, Dr. Owende. The floor is yours, or the microphone is yours. Thank you.
Good evening, everyone, and welcome to this session on understanding menopause and innovations in treatment. We have divided this presentation in three topics. The first one will be presented by Dr. Dorcus Muchiri, and then I will be giving highlights on treatment, and then we'll have Dr. Moses Alobo discuss innovations in treatment. Dorcas, the floor is yours.
Thank you, Dr. Owende, for that lovely introduction, as well as our chairperson for COGS, Dr. Kireki. I tend to read just before bedtime to put me to sleep. That's where I get the time. So it looks like I do a lot, but it's just 10 minutes every day. So that's the secret. Hopefully we can all jump on board. But the purpose of today's discussion is not on the books. It's about this heavy subject, menopause. We are going to try and make this presentation not as intense. We have had previous seminars and discussions around the subject, and it's quite a lot to put on board in sort of hourly meetings. So we are going to try as much as we can to demystify these hormones and at least give practical advice and guidance on how to take care of our women. So we'll jump right in. That's all of us, lovely pictures. We have no declarations, at least for myself and Dr. Owende, to declare in terms of conflict of interest. Dr. Moses Alobo is representing LVH, and that's sort of his area, with no ethical considerations to be considered for this lecture. If you've attended any of my teachings before, I like to use Mentimeter because I think it's useful to understand what value we are adding to the conversation and the discussions. So if you can get your phones out quickly, as always, a QR code on the right-hand side of this presentation will take you to the Mentimeter. We'll not have too many questions for this time. But if you could quickly join onto Mentimeter, and you'll find a couple of questions that I'm going to share. It helps to make this a bit interactive, and I can tell that there are 51 participants online. I can also tell how many will answer. I won't be able to know who has answered and who's not. That's a downside, unlike a typical lecture. But that's question number one. And you can also join online at menti.com and use the code that is available to you at the top, 19737927, if you don't have a QR code to join. The first question here is regarding my knowledge on menopause. I'm very confident, I'm 50-50, I'm not confident, and I'm curious to learn. So I'd be very interested to see what the answers look like. So I'll give a minute so that we are not too pressed for time to answer that question. So regarding my knowledge of menopause, the QR code is on the bottom left. The joining instructions are also at the top. Yeah, thank you for whoever has answered. Lovely. Thank you, keep them coming. Yep, very confident. So the beauty about Mentimeter is I can tell when people are being interactive or not. So waiting for a couple more answers. And you can join this on your internet. You can use it on your phone. Thank you. So giving some time for those who are not very tech fast. QR code on the left side, or you can join at menti.com and use the code that's available. I just briefly answer regarding your knowledge on menopause. How do you feel? Are you confident? Are you feeling like you're just fluffing about in the waters and you're curious to learn? Or you're 50-50? So we've got 8 people. There's 52 of us on the call. So if we can endeavor to answer. The next one is also a question. So keep the Menti open. Yeah, so 20% have answered. I hope I'm doing that right. Yeah, about 20% of us. For anyone who's joining us, we've just started and I'd like to know your knowledge on menopause via the Menti meter. There's a QR code just at the bottom, and there's a way to join online as well. If you go to menti.com and you key in that code, you'll be able to answer, and we can have a better interaction when we see how useful this information is going to be for us. So it looks like a lot of people feel 50-50 at least. It's probably because we've talked about this subject a bit. In the past year, we had a pre-Congress workshop that we ran that also gave some valuable information, and we are aiming to keep giving this information so that we are all comfortable with the subject. I'm going to wait for this to get at least to 20. So I think the faster we answer, the faster we shall move to the next sort of slides. I'm nearly at 1 minute, my 1 minute mark. Thank you. So 14 people, at least 6 people should quickly log on and answer. And then we'll move to the next ones. In the interest of time, the next question is coming up just now. What's the number of possible women in menopause that I have seen this week? My answer is 5 to 10. I only have one clinic at the moment that runs in the afternoon. So I've seen 10 women in my clinic yesterday. So let us know, are we seeing a lot of menopausal women, or is it just so-so in the last week? Yep. Yeah. So the beauty about seeing these answers is that we can tell there are people who are quite busy. It's probably all that they're doing, seeing menopausal women. There are some of us who may be younger in the profession, so we're not seeing that many. If you're like myself, with only one dedicated menopause clinic, then we ram everything into that. So it depends on how the clinic goes. So if you are happy to just go onto menti.com, use the code at the top, answer how many women have you seen in menopause this week. That question will remain as we go on our presentation, so I won't take too long in terms of that. So I'm going to define menopause and how we've sort of arrived to this subject in the 2025, in the year 2025. We've always described, or at least it was told to us, that menopause will occur around 51 years of age. And now, with time, people have given it a much larger range, 45 to 55 years. And the theory is that Africans or women of African origin might be having the menopause, might be going into menopause earlier and having worse symptoms. The transition before
Dorcas?
the period, yes?
Sorry, we are not seeing your slides.
Oh, are you not? Oh,
Yes, yeah, so please upload again.
let's see. Stop share.
I'm sorry for that.
No, that's fine. Thank you for saying that. Sometimes it's done that it gets confused by the questions.
Yes.
Yeah, so slideshow. Okay. Okay, so just sharing that again. Sorry about that. Okay. Are you able to see that now?
Yes.
Okay, fine. Thank you. So I was talking about perimenopause and what that is. So before the period disappears for after 12 months, which is where we count menopause from, the months or the years that are just slightly before that are considered perimenopause. And what a lot of clinicians or even women who have experienced this have not openly talked about is the drama that happens when the hormones are all over the place. And this is where most women tend to struggle before their body settles into a lower level of hormones. The commonest symptoms that have been discussed, and again, this is on a global platform, some of the work that I've been involved in shows different for what we are seeing in Kenya. Hot flashes are approximately 85% of women experiencing that, and how they describe it is that they get sudden feelings of heat, often accompanied by night sweats, sweating and discomfort, and it can occur whether it's the day or the night time. They can be quite frustrating, annoying, waking women up, and more in the conversation is how they are relating with their partners, their husbands, when it comes to hot flashes, particularly at night. Night sweats and chills. So the chills part has also not been well described by a lot of people. So they get these episodes, they can be sweaty, but a lot of women are also getting very cold at night. And this leads to sleep disturbances. What is less discussed is vaginal dryness, especially around our culture and how we have been sort of brought up to discuss private parts and private matters. Mood changes, which are often attributed to that's just how women are, or that's how she is, that's her personality. So a lot of high highs and really low lows, all the way to the extent of depression and depressive illnesses. Sleep disturbances, very particularly worrisome for women who are in corporate, who are at work, because then it affects their work function the next day. A lot of women are describing this weight gain around their mid area that is very difficult to shift, even when they have not changed anything in terms of their eating and in terms of their diet and their exercise. And in fact, it pushes women to go into heavier exercise types, and they get a lot of depression mentally just because of this weight business as well. And decreased libido. I am very curious to hear people's experiences about discussing libido. Every single woman I've spoken to in menopause has described some change in libido, either decreased, some of them it really increases, but of course it's affecting relationships and marriages. So I tend to think about these symptoms from a head to toe perspective. I've been collecting a series of weird symptoms that people would not attribute to menopause, including tinnitus, hair falling, and it confuses the picture even further. But as we address it, just think head to toe, all the things that could get affected and have estrogen receptors will have some symptoms. I put this slide here just to demonstrate the straw staging. Some people have had a bit of problem understanding it, but I find this diagram very easy not necessarily for usefulness, but I show this to patients as well, because the stages have been described. They're quite hard to, when you talk about stage 1, stage 2, eventually what it means for the patient is that she's going to be struggling at some point. But they give also the descriptions of reproductive, menopause transition, the perimenopause phase, and the post-menopause. The reason I like the straw staging is it also shows you the changes of the hormones, i.e. the follicular stimulating hormone, and it talks about how periods vary, and especially that time around the perimenopause, where the cycle length can vary and it can be either too frequent or too infrequent until the time where it starts to skip more than 2 skipped cycles with an interval amenorrhea time of 60 days. So I just want to particularly bring up these menstrual cycles because it confuses as well with polycystic ovarian syndrome. We know that those patients will also have interval amenorrhea, and it can easily confuse the picture, especially for those who are trying to conceive. Now, I'm going to be discussing from a clinician's perspective what it means, what the consultation looks like. Dr. Owende will be addressing the actual treatments. I've found that menopause consultations will typically, if you're very deep in the initial phase, will be 1.5 hours. They tend to get lighter once you've gone through this first bit. And I ask, and what I've been at least found useful from my seniors is asking, what is the most concerning symptom you have? So remember, these ladies will tell you everything. They will probably have something somewhere from head to toe. And that's going to be a lot of things to sort of address in one sitting. It could take you 3 or 4 hours if you went phase by phase. And not to invade on what they want to discuss, but we want to address the most concerning symptom because there's what has brought them to hospital or to your clinic. More importantly is that women may have symptoms that they don't consider concerning, but you as a clinician would be concerned about. So you still have to ask those questions. So for example, bone pain in a woman who's come for a menopause consultation was hot flashes. The hot flashes may be her most concerning symptom, but if she also mentions in your questioning that she has bone pain, then you want to think about osteoporosis. In a consultation, I tend to discuss these stages of menopause just to explain what is happening because a lot of clinicians ourselves, but even the women don't understand what is happening, the impact on the quality of life. And here I'm talking about the 3 big things in terms of long-term health risks. So that's cardiovascular, bone health, and mental health, and the impact on the quality of life. And we're talking about the full scope, including living with their children, their husbands, their partners, and work, and how that gets impacted. In the same sitting, we like to go through all the therapies that are available, whether it's hormonal or alternative and complementary therapies, especially in this day and age where everyone is talking about HRT. Then a patient can come when they're very set in their minds that they want hormones, or they're very set that they don't want any hormones. So for you as a clinician, you want to be able to address all of those, including the evidence basis and the approaches for that. And then you want to discuss consent, to discuss their personal health, even with other physicians or clinicians, because menopause, as we know it, is not one discipline that belongs to the obstetricians, gynecologists in this case. So you may need to talk to a cardiologist, you may need to talk to a mental health specialist, or you need to get informed consent. We also want to discuss their menopause experience and the diversity with which it happens. This is one of the things that I've noticed over time. Not all women will have all the same symptoms and present in the same way. So you want to reassure this lady that whatever she is feeling is not unusual, and it's her experience, and being able to give space to her explaining that experience, rather than having comparisons that, some, like all people will have hot flashes. I've realized that having conversations like those will make the ones who don't have hot flashes feel like they're not, they almost have a new way that they're describing, that they feel like they're being left out or they're not normal because they don't have hot flashes. And then how they're sort of seen to judge patients or women who are going through a more severe experience. And then engagement strategies to consider how to initiate conversations with even other women around them. So when I speak about conversations on menopause, I like to create a comfortable environment. And it's very interesting that when I first walked into the first menopause clinic I was sitting in, it was very, very hot in the summer where I'm placed. And all the women were coming and fanning themselves. So you can imagine if it is someone is going through a hot flash in a hot environment, in a hot room. To ensure there's privacy, relaxed area for having these discussions, but even temperature, you have to be very wary about what the actual physical environment looks like. Normalizing the conversation, framing menopause as a natural transition that every woman will experience, rather than saying that it's a medical condition that requires, it's a disease. Because we've had women who have come and they were told that, this is a disease, you're having this as a disease, and this is what is happening to you. Using common languages and phrases, like many women will go through the menopause. Let's talk about what changes you may be experiencing as you age. I have had some women who are in denial about aging, which is quite an interesting concept. So 60-year-old who would like to remain 30 forever and is in denial about the fact that she's aging as well, and asking open-ended questions. We've been trained in med school about how to ask open-ended questions, so that shouldn't be a problem. Listening actively, I think, is something that at least we are good at, but being able to respond to what you hear. So showing empathy by summarizing their concerns, clarifying any points, avoid interrupting or allowing them time to express their feelings and questions. And this is one of the things that makes a menopause consult, especially initial, very long. You want to allow this lady to be able to express what she's going through. Providing educational materials, offering pamphlets and resources where this information is possible. We are hoping to be able to come up with a couple of these information leaflets, and this can be handed out, by authorization from COGS to patients and people who are seeing these women. So using reputable sources, encouraging patients to read and come back and ask questions in their follow-up visit. And then addressing common myths that are surrounding the menopause. So, for example, some people will be like, that menopause must be a dreadful experience. So like I've explained, some women are not going through this dreadful experience. In fact, the data suggests nearly just over a quarter women will have a dreadful or very bad experience. Most people tend to, once they understand, they tend to sort of flow or scoot over it without any problems. And encouraging a discussion about their beliefs and doubts to clear up misconceptions. You want to discuss the symptoms and the treatments. You encourage follow-up questions, and then being sensitive to emotional responses. I've recently had patients who said, I explained to my doctor everything that I was feeling, and then they just said, that's normal. That happens to old women. Being able to validate their feelings and encourage them to express their worries and their concerns, what they're going through, what they're worried about in terms of aging and health, and that just being a comfortable person to speak to in terms of those. I've had patients who are in their early 40s, late 30s and 40s who have gone to doctors, even gynecologists, and expressed what they're feeling and have been told, you're too young, you can't be in menopause or you can't be perimenopausal. Again, a very difficult conversation to have in this day and age, and having to undo what that means for that woman. So just being sensitive to those. You want to highlight the importance of support systems because when patients come to us, they think that they are the only ones who are experiencing this. And I'm happy to see that a lot of support groups online and offline, locally, physically, are happening around Kenya and Nairobi specifically. I am hoping that we can see this going out even to the rural areas where these women are technically just going through life by themselves. Emphasize the need for individualized care. Not every woman will have the same symptoms. Menopause is unique for different women, encouraging them to voice their preferences. And then for ourselves as clinicians, staying updated on the latest research. I've felt like in the last sort of 3 or 4 years, every day I've woken up, there's something new in the menopause space. So if you're not actively seeing this information or keeping updated, I would be suggesting that you send your patients or refer them to people who are living, sort of in the hormone space, and it's easy for us to sort of keep updated. But it's important for you also to be able to keep yourself updated. There's nothing as difficult as having to undo information that someone else has given that was not updated. So I'll go briefly through and very quickly through the myths and facts because I think I've taken too much time. Myths and facts about menopause: that it happens suddenly, it's a slow process. Hormone therapy, that it's dangerous. Dr. Moses will be alluding to and going through the WHI study and what has come of that and how we are going to try and undo this. Not all women will need medication, and hot flashes only lasting a few years, that's inappropriate information. In fact, I always quote my mom, who's had 15 to 20 years of hot flashes. So those are some of the myths. Quickly talking about the questionnaires that we use in clinic, the menopause rating scale, green climacteric scale, and Mencol. This will assist you as a healthcare provider to gauge the impact of the symptoms, as well as once you start them on treatment, how to monitor over time their rating scales, and you can put this in the patient's file. You can give them to fill them themselves, or you can talk them through it. And then in terms of compliance, ensuring that once you started medication, you're playing around with the doses until it feels appropriate for the patient, and then encouraging open dialogue and decision-making. So I'm going to go quickly and let Dr. Owende take over from here. Thank you.
Thank you very much, Dr. Dorcus Muchiri, for that comprehensive introduction. I think you have set the tone very well. I will now take us into treatment, and this could begin and end at this slide. Indeed, menopause is a natural biological transition, as you have said, and it is marked by the cessation of ovarian function and a decline in estrogen levels, leading to a wide array of physical, psychological, and metabolic changes, as you have mentioned. And these changes affect multiple systems in the body with varying severity and prevalence globally. It is influenced by genetics, lifestyle, as you have mentioned, and also sociocultural factors. So this image that is projected maps out the hormonal and biochemical changes associated with aging, especially in women, and how these changes affect different body systems. And this is the basis of the treatment options that we discuss with women. For instance, vasomotor symptoms and sleep increased. There is increased noradrenaline, cortisol with decreased dopamine and serotonin. And this explains the hot flashes that women experience and sleep disruption. In regards to mood and cognition, there's a drop in testosterone levels, DHEA and DHEAS, and this affects neuroendocrine balance, increasing the levels of cortisol and decreasing the beta endorphins and GABAergic functions. When you look at the urogenital functions, there's reduced androgens, as shown on these slides, and estrogens also lead to symptoms like decreased libido, as Dr. Muchiri mentioned, and vaginal dryness. Skin and hair is also affected owing to the lower testosterone levels and DHT that cause hair thinning and skin aging. For bone health, there's a reduction in estrogen and testosterone with increased bone resorption markers, which drives osteoporosis. And for the muscles, there's reduced testosterone and growth hormones that contribute to the sarcopenia that is experienced in this age. For cardiometabolic symptoms, there's decreased DHEA and testosterone and increased LDL, reduced HDL, and this leads to a higher cardiovascular risk. And overall, testosterone and DHEA are common denominators impacting everything from mood to metabolism to muscle tone. Next slides, please. Dr. Muchiri? So in terms of treatment options that we consider in menopause, there is hormonal treatments and there is non-hormonal treatments. So I will start by discussing the hormonal treatments that are available. These are mainly estrogen-based therapies, and the indications include vasomotor symptoms, as has been mentioned, and these women present with hot flashes, night sweats, and vaginal dryness, amongst many other symptoms. Considerations include tailoring the treatment to the women's individual risk factors, which we are going to look at, including history of breast cancer and cardiovascular disease. Progesterones are not equal, and we are going to look at this later, and even during the presentation by Dr. Moses Alobo. You will see that the androgenic progesterones, we are now doing away with them because of the increased risk of breast cancer for those who use the androgenic progesterone. So the indications are essential for women with a uterus, generally to counteract the potential negative effects of estrogen on the endometrium. And the forms of progesterone include progesterone tablets, intrauterine devices, and injectable options, but these injectable options are rarely used. So I put Tibolon here, not because the risk with Tibolon reduces, but just to show you, Tibolon is a selective tissue estrogen regulator, abbreviated as STIA. However, it has estrogenic, progestogenic, and androgenic activity. But in terms of risk profile, I think this still compares with the other hormonal therapies. Please, next slide. So the considerations, if a woman has the uterus intact, then you should use a combination of estrogen and progesterone to reduce the risk of endometrial hyperplasia. And this can be administered as a continuous cycle, as a continuous combination, or cyclic therapy. We tend to use cyclic therapy for women who have not reached menopause but are in perimenopause with severe symptoms, and continuous combination therapies of estrogen and progesterone for women who are post-menopausal. And without a uterus, estrogen therapy is used alone, and this is appropriate. You do not need any progesterone for those who have been hysterectomized. Next slide, please. So these formulations of hormone include oral. We're going to look at this. Generally well tolerated for most women. However, there is the risk of fast pass metabolism and the risk of clotting. We are going to look at this. Then we have these formulations available as transdermal patches. This delivers hormones through the skin, avoiding the fast pass metabolism. Then there are topical gels and solutions. There are vaginal rings, tablets, creams. We are going to look at that. And then some places there are implants and injectables. Next slide, please. So for progesterone formulations, as I mentioned before, that the preferred progesterone is the micronized progesterone and micronized progesterone and dydrogesterone. So those are the preferred progesterone, because the studies that have been done, which you're going to look at later, have shown that there is less risk of the development of breast cancer with these progesterones than with the androgenic progesterones. And the androgenic progesterones that I'm talking about are the medroxyprogesterone acetate and norethistron acetate. Progesterone is also available as intrauterine device. I think locally we have 3 or so devices from different companies, and these are used for women who still have their uteruses. And some places have transdermal progesterone creams. I have not seen it locally. The progesterones that we have locally are the micronized progesterones, which can be administered orally or vaginally. The transdermal progesterones are available in some markets. Next slide. So let's just look at the options we have after you've seen a woman who has indications for menopausal hormone therapy. And here I will refer to this as a healthy woman. So in a healthy woman, depending on the age, you could give sequential menopausal hormone therapy. And in sequential menopausal hormone therapy, it means that you are combining estrogen and progesterone for nearly half of the cycle. And in this sequence, the woman will experience some bleeding. So it is very good for women who are not yet menopausal, who are approaching menopause. And for those who are menopausal, we give the continuous MHT. So for options for sequential MHT include estradiol with micronized progesterone. Now, estrogens, the best option for estrogen is estradiol valerate, which is a natural estrogen. It is safer than the synthetic estrogens. It's available in its micronized form, whose bioavailability is better than the synthetic forms. It is convenient. It can be used for oral route or as conjugated estrogens. But when you compare the estradiol valerate and CEE, CEE is conjugated equine estradiol. The estradiol valerate is better because it is natural than the CEE. So the combinations used in sequential therapy for women in the perimenopause include estradiol with micronized progesterone, which can be used orally or vaginally depending on the preference of the woman. Or you can use estradiol with dydrogesterone as a combination for sequential treatment. But because sometimes the cycles are all over the place, and just to guide the woman in terms of how to take the sequential treatment, some combinations come with very clear instructions that from a certain date to a certain date, you take both estrogen and progesterone, and the estrogen continues throughout. And this allows for breakthrough bleeding. For the continuous one, I had mentioned that this is good for postmenopausal women. Again, the combinations that are available include estradiol and micronized progesterone, which can be given orally or vaginally for women with intact uteruses, and also estradiol with dydrogesterone, and dydrogesterone is given orally. In the sequential dosing, dydrogesterone is 10 milligrams. Please take note of that. And in the continuous dosing, dydrogesterone is 5 milligrams. However, for micronized progesterone, you could give 100 or 200. But some women may present with bleeding in the first 3 to 6 months of treatment. And if you're giving the micronized progesterone at a dose of 100, you may increase it to 200 so that the bleeding stops. And if the bleeding continues after 6 months, you might want to evaluate again. There are also transdermal combination, and that includes estradiol that you could give with a combination of levonorgestrel, and this could be levonorgestrel IUD, or you could give it with micronized progesterone. This is transdermal estrogen, that is estradiol given transdermally with a combination of micronized progesterone given orally or vaginally. You can also give the transdermal estrogen with dydrogesterone. 10 milligrams for those who have not reached menopause, and 5 milligrams for those who are already menopausal. This group of women can also benefit from transcutaneous formulations where they are available. And there's also, I know some of you might ask about Tibolon. As I mentioned earlier, that Tibolon is a selective tissue estrogen regulator, abbreviated as STIA, with similar risk factors. However, it has estrogenic, androgenic, and progestogenic properties. Then for where tissue selective estrogen complex are available, and here we have the basidoxifene, in combination with CEE, but this can also be combined with estradiol. I have not seen this combination only in literature, but I think probably at during the Q&A, we can have a discussion on this. And there sometimes systemic treatment is contraindicated. For such women, you could give topical therapies, and these are available as capsules, as rings, as creams, as gels, and also there are DHEA capsules to be inserted vaginally. And for women with very low libido, you might consider androgens. Now, in our market, for a long time, we haven't had the female testosterone. What we have is the male testosterone gel. And if you are going to use the male testosterone gel, the appropriate dosing would be a 10th, basically 1/10 of the dose. And that comes to about 300 micrograms of the usual formulation for men. Next slide. So it's important to also note that there are contraindications, and also that not all women need HRT. So usually during the consultation, you establish using the tool that was presented earlier by Dr. Dorcus Muchiri, you'll be able to establish whether the symptoms are very severe, mild, or moderate. For women with mild symptoms, you discuss, again, the benefits and the risks. So for some of those women, especially if they have some of the risk factors, you might consider some non-hormonal therapies for them. But there are women whose lives literally stop because they're in the perimenopause period or the postmenopause period. So for such women, MHT is indicated if they do not have a contraindication. So these are some of the contraindications for both oral and transdermal estrogen-based therapies, and these include known or suspected history of breast cancer, or known or suspected history of other estrogen-based cancers like uterine cancers, or women who have had a hysterectomy and have had no remaining evidence of disease may still be candidates for HRT, especially if it interferes significantly with their quality of life. Acute deep venous thrombosis is a contraindication, history of VTE is a contraindication, and history of blood clotting disorders. And the most common is when you have a diagnosis of factor V latent mutation, then this will be a contraindication. Other contraindications include active or history of arterial thrombotic diseases, such as myocardial infarction or stroke, or carotid artery thrombosis, jugular thrombosis. And lately, we are seeing a number. I know in one of my wards, we have a woman in the puparium who has bilateral jugular thrombosis, and this is as a result of an autoimmune condition. So for such a woman, yes, it might resolve, but later on, if she goes into menopause, you must take that history. Then that would be a contraindication. Again, chronic liver disease is a contraindication. Migraine with aura is also a contraindication. However, these contraindications that I've mentioned do not apply to transvaginal estrogen therapies, as the serum concentration of estrogen from this route is extremely low or non-existent. Next slide. So I'd like to mention some non-hormonal treatments that we use, especially when MHT is contraindicated or when the woman does not desire to start MHT. So SSRIs or SNRIs have been used mainly by our psychiatric colleagues, but these have been shown to lift mood symptoms, and they can also help with some hot flashes. And examples in this group are venlafaxine, escitalopram at appropriate doses have been shown to manage hot flashes. Gabapentin, though I don't like gabapentin very much because of the side effects, for menopausal symptoms, you need very high doses that may not be very tolerated by the woman. So, but it is a consideration if you do not have any other option, or if all the other options have not worked. For women with sleep disorder, I'm going to look at this later, and have had cancer therapy. MHT is contraindicated. You could consider for sleeping, you could consider zolpidem or Stilnox. I think it's available in our market as Stilnox, and this is basically for sleep. Clonidine has also been used as a non-hormonal treatment for symptomatic women with hot flashes, and also vaginal moisturizers and lubricants are non-hormonal options to relieve vaginal dryness and discomfort during intercourse. Now, there's been a discussion on the role of phytoestrogens and herbal supplementations, and even acupuncture. Now, new evidence is that acupuncture, while it has been used by many women, maybe the benefits for menopausal symptoms may be very minimal. However, I know there are lots of women I have met recently who are on herbal supplementation. The problem with this is you do not really get the appropriate herbal dosing. And so when used in large amounts can actually be harmful, because they use this to manage hot flashes, to manage poor sleep, excessive sweating. And what we don't know is their safety levels. And of course, people think that when it is labeled herbal, then it is safe. But we can just have a whole session discussion on phytoestrogens. Next slide. So at this point, I'd just like to mention that a diagnosis of cancer is not a contraindication for menopausal hormonal therapy. So on this slide, I have put some of the cancers that affect both sexes where MHT might be indicated, especially if the symptoms are severe. And this include gliomas, head and neck cancers, they can have MHT, if symptoms are severe. Lymphomas can have MHT, gastric and esophageal cancer. So this, we have to be a bit cautious because some of them actually have estrogen and androgen receptors. For kidney cancers, they can have MHT. Colorectal cancers can have MHT if indicated. Bladder cancers, there is no data on bladder cancers and MHT. So this one, you weigh the benefits and the risks. Malignant melanomas can have MHT. Pancreatic cancer, they can have MHT. Hepatocellular cancer can have MHT. Some lung cancers can have MHT, and even thyroid cancer. So the fact that one is diagnosed with cancer does not mean that we should not alleviate their symptoms on, that are related to menopause, because it can really be troublesome. And remember, when one already has that diagnosis of cancer, even its treatment alone affects their memory, sleep. Then on top of that, menopausal symptoms can be quite troublesome in this group of patients. Next slide. So can we give MHT after cancer in females? So as I mentioned before, that for estrogen receptor positive tumor, breast cancer, for this group of patients, MHT is contraindicated. For ovarian cancer, some ovarian cancer with troublesome symptoms, especially if they have had TAH, BSO, can have troublesome symptoms. And this group, say, with high-grade serous, endometrioid, mucinous, clear cell, you might actually consider MHT for this group of patients. But you need to avoid it when you have low-grade serous tumors, granulosa cell tumors, and sex-cord-stromal tumors. For uterine cancers, you can prescribe MHT for the endometrioid type, the serous type, the carcinosarcomas, especially if the symptoms are troublesome. Again, vulval and vaginal cancers, many I know are related to HPV, but if symptoms are troublesome, can still benefit from MHT. Cervical cancer, non-HPV related cancer require caution, particularly the gastric subtype. Next slide. So this is an algorithm for women who have been treated for breast cancer and have troublesome menopausal symptoms. So you need to establish the nature and the timing of symptoms and the patient's priorities for treatment. Consider concomitant medication. Are they on the AIs or tamoxifen, or you could also offer self-management strategies. And if the vaginal symptoms are troublesome, these women will benefit from vaginal estrogen creams because very little or none at all will be absorbed. But you need to discuss this with the oncologist taking care of them. When the vasomotor symptoms are troublesome in patients with breast cancer, you could offer non-pharmacological treatments, and this include the purpose-driven cognitive behavioral therapy. Hypnosis has also been shown to help. I mentioned acupuncture early, but again, I think there's very minimal effect on vasomotor symptoms. And some pharmacological treatments for this group of patients include SSRIs, I mentioned before. Now, there's this new finding on the other benefits of oxybutynin, and this could be offered to women who are breast cancer survivors, and this will help alleviate troublesome vasomotor symptoms. And there's a new drug not available in our market. This is called Veozah at a dose of 45 milligrams. It's not here. Probably Dorcas will be mentioning it later, probably during Q&A if time allows. And then after initiating these pharmacological treatments or the pharmacological treatments that are non-hormonal, you review the efficacy after 1 to 2 months. If it is not working, try something else. But usually after about 2 months, you evaluate. But avoid these medicines, that's the Veozah and the SSRI in patients who are on tamoxifen. Next slide. How about sleep disturbance after cancer? Again, cognitive behavioral therapy has been shown to improve insomnia, fatigue, and sleep quality after breast cancer treatment. And CBT now, even in our market, we have seen online CBT sessions. And I think we should really embrace this, because especially when women are from far and will have troublesome symptoms, have been treated for cancer, you could link them up with a psychologist for CBT. Zolpidem, I mentioned earlier, has been used to improve sleep in this group of patients. In our market, I think it's available as Stilnox. Usually a dose of 10 milligrams at night will improve their sleep. And also melatonin has been used in this group with good results. Next slide. Here, I wanted to mention the risk-reducing salpingo-oophorectomy for women with BRCA1 and BRCA2 gene mutations. So for these women, sometimes very young, they opt for risk-reducing salpingo-oophorectomy. However, as soon as they have this surgery, their life literally stopped because they have severe vasomotor symptoms. They are not sleeping, they are sweating, and within a year or two, they have memory, cognitive dysfunction. So for these women, you might need to discuss with an oncologist, gyne-oncology, and also medical oncologist, whether they are safe to use MHT. And for some cases where symptoms are severe, you might consider that. In fact, there's a study that is going on whether the risk-reducing surgery will include oophorectomy or just a tubectomy. So I know it's in North America, Australia, and in some parts of Europe. We don't have any centers in Africa. And I think this is a challenge to all of us now that we're seeing so many cancer cases, that for those women, we offer risk-reducing salpingo-oophorectomy. Can we just do risk-reducing salpingectomy and leave the ovaries? just so that they benefit from continued hormone production and reduce the risk of cognitive dysfunction that comes soon after, and also the severe vasomotor symptoms, sleep, and poor quality of life. Next slide. So I'd like to hand over to Dr. Moses Alobo. I think that marks the end of my presentation on treatment. We welcome questions. So over to you, Dr. Moses Alobo.
Thank you. Thank you so much, Dr. Owende, for that brilliant presentation and introduction. And again, Dr. Muchiri, that was really good. We would like to just say that we are happy to be here, Dr. Kireki, and also to the COGS fraternity for allowing us to have this particular discussion today. I am from the pharmaceutical industry, where I've spent approximately 15 years discussing various different products. And next slide. For the next few slides, I'm going to show you, some evidence towards what Dr. Muchiri and also Dr. Owende has just discussed about. Next slide. So we are happy to tell you that we do have the estrogel, and we'll be talking about the pump actuations in the market. It should be in your local pharmacy. If it's not, if you put in a prescription, then the local pharmacy should be able to get it from the wholesaler. But basically, the indication that we have is for hormone replacement therapy, for the vasomotor disorders, the genitourinary syndrome of menopause, and also the psychiatric disorders and associated conditions that are there, including sleep quality, mood and anxiety, cognitive functions, and also quality of life. The other thing that has probably not come out is prevention of osteoporosis in menopausal women at a high risk of fractures, especially those who are intolerant of or contraindicated for other medicinal products. This particular product should be able to assist. Next slide. Going to tell you a short story about the WHI study, the Women Health Initiative, that has up to date recruited approximately 161,000 patients. It started in 1993 and had its initial readout in 2002. And at that particular time, it indicated that there was a high risk for breast cancer, stroke, and heart disease for postmenopausal women. Now, the interesting thing about that particular readout is that the first readout only included patients who were, way postmenopausal and above 60 years of age, with some of them probably should not have been in the study. But again, there have been a lot of discussions about that first readout. But the consequent readouts of the WHI study have actually indicated that hormone therapy, and they were using the conjugated equine estrogens and also the medroprogesterone acetate, which, yes, they're still in the market, but rarely used. We now have the transdermal versions, which we are talking to you today about. But the 18 years follow-up study has now shown that it was not associated with any, all-cause cardiovascular disease or cancer mortality following this readout. So next slide. And they've been, please keep going until the bottom again and again. Yes, so there've been a lot of international guidelines, revisions, one slide back, and most of the recommendations are technically the same. There are obviously some differences between the various different guidelines that are there. But it's important to mention that, of course, hormonal therapy remains the most effective treatment for vasomotor symptoms and also genitourinary syndrome of menopause, and also prevents bone loss and fracture. It's also important to understand that the use of transdermal as compared to oral estrogen preparations may be considered less likely to produce thrombotic risks. In this particular slide, there's a readout from the various different guidelines that are there. That transdermal MHT, for example, confers lower VTE. It prevents BMD loss. It's probably a better option for women with diabetes, high blood pressure, CVD, and also gallbladder disease, especially when compared with oral formulations. And then it should also be used in HTD and micronized progesterone may be less thrombogenic than other progestin formulations. The other thing about micronized progesterone or utrogestan, which is also in the market, is that it has some sedating effects. It reduces wakefulness with no effect on daytime cognitive function. And if sexual function or libido are concerns according to the NAMS guidelines, then transdermal estrogen may be preferred versus oral. Next slide, please. This is the dosage. Next slide. This is the dosage which has been brilliantly described. So again, I will not go into it, but just mention that one pump actuation will give you 0.75 milligrams of estradiol, the natural estrogen. Two pump actuations, of course, 1.5. And in the next slides, I'll be showing you how to administer the product. Of course, it's used with utrogestan 200 milligrams per day, day 12 to 14, for the sequential combined regimen where the woman is still on her menses. But for postmenopausal women, the dose comes down to 100 milligrams per day, continuous combined regimen. Next slide, please. You press to dispense one dose. You apply to a clean, dry, intact skin at the same time each day. Anywhere between, one arm, wrist to shoulder, inner side. You wait for it to dry. Do not massage or rub. Now, once you do that, it will take approximately 3 days for you to reach stable state within the serum of the medication. And then after you apply for each 24-hour session, it releases approximately 10% into the bloodstream at each instance. And I know there was a question at some point around, does obesity affect administration? Our current readout is no, but again, it is something that we are looking for data around. So the next slide is a readout of studies that were key in the registration of estrogel. The first one showing that by around week 4, you actually get approximately at the dose that was chosen, 90% of reduction in frequencies, of moderate to severe hot flashes. Next slide. And severity also goes down. Again, for severity, you see the effect, especially around week 12. Though our current, information that we are receiving from the field from patients that have already used it, there seems to be a good effect even before week 12. Next slide, please. The this slide really says that the maximum actuations that you can give from the estrogel is 4, and the reaction that you get is actually dose dependent. So of course, if there is still severity, you can increase the dose up to a maximum of 4 actuations from the pump. Next slide, please. And in this particular slide, it's really the evidence from the Replenish trial, which was used for the registration of protection against endometrial hyperplasia of micronized progesterone in MHT. Again, I will not go into that just because of time. So the next few slides have been put there because of the frequently asked questions that we have received so far, that the product has been in the market, and we thought that we should discuss it with you. First one being that the site reaction from the gel is quite low, especially if you are to compare it with the patches. Next slide, please. This slide also just in a way insists that the efficacy may be just about equivalent to the patches, but you get lesser skin intolerance issues. Next slide. The Chronos Early Estrogen Prevention Study 2012 had a look at just about 700 postmenopausal women, but they were recently menopausal women aged between 42 and 58. And the idea was to give them oral conjugated equine estrogen versus transdermal estradiol and also placebo, with a view of having a look at their carotid artery intima media thickness, and also have a look at their VMS, sexual function, and also quality of life. Next slide. And what was seen is that there was no significant difference in CIMT progression between the oral and transdermal. For the vasomotor symptoms, the MHT significantly reduced the frequency and severity of hot flashes and night sweats. And mood was also improved, really underlining the fact that, which had also been seen in the WHI study, that if you were to start the management of, menopause symptoms early rather than late, then you do get some form of protection in CIMT. And I think we'll be seeing another set of slides around this. There was progression in the initial WHI study that gave that alarming readout. Now, that said, if a patient already is on, if they started early on estrogel treatment or management, and then they progress beyond 65 years of age, then you could still continue, because there are studies that show that the protection would still continue. Next slide, please. This slide is very interesting, and it speaks to what Dr. Owende was talking about. Just being aware of the contraindications and how to actually take care of them. So again, it's a 20-year follow-up of the WHI study showing, patients were given estrogen alone versus those who were given oral estrogen plus progesterone, and the risk profile that was seen. The dotted line is 0.01% of events that were seen in this 20-year follow-up. And as you can see, the combined oral estrogen progesterone, had some form of a readout around breast cancer, stroke, CHD, PE, and DVT, but all of them were less than 0.01%, which means that if you have patients who already are predisposed in whatever kind of way to these particular events, then it is better not to put them on the drug. Next slide, please. And then here again is just to insist and say that, well, different types of doses that were being used. The earlier that you start, the estradiol versus if you are to start late on CIMT progression, there is definitely a difference between the two. Next slide. This chart represents pooled data from a meta-analysis along 7 randomized studies. Again, old data, 1974 to 2006, but really shows that oral estrogen is associated with an increase in HDL and a decrease in LDL. And of course, the administration of the gel transdermally demonstrates a less significant effect on decreasing LDL, increasing HDL, the oral estrogen also tends to increase TGs, with transdermal therapies tending to decrease the TGs. Next slide, please. The experimental and clinical data indicates that transdermal estradiol and micronized progesterone could represent the optimal MHT, particularly in women at risk of thrombotic adverse events. I think that's all I want to say, just because of time. Yes, the efficacies with other medications might be the same, but you do get some form of protection when you use the gel. Next slide. This slide is also combined comparison between 15 observational studies between oral versus the gel. And as you can see, if you look at VT, DVT, CVA, those are predilection to having a higher risk with the oral versus the gel. Next slide. Next slide is important. Sorry, next to the next slide. And sorry, I'm rushing a little bit because I really want to save some time for discussions. This slide is a combination of absolute risk profile, because within the studies, there is usually relative risk assessment. If you are to compare different types of studies, then of course you need to consider the absolute risk profile. And in this case, various different players came together and put this together. And it is quite clear that if you were to use MHT with estradiol and micronized progesterone as your comparator, then it is quite clear that obesity, alcohol at 2 units per day, tobacco, nulliparity or first baby born late, a family history, especially first degree of breast cancer after the age of 50, and then if you have the BRCA gene mutation, all those that I've mentioned have got a higher risk profile for breast cancer than MHT. So out of all this, exercise is what seems to be protective, at least from this particular readout. Next slide, please. So again, I will not go through all this. I'll just move over to the next slide and say that as it is at the moment and has been demonstrated in the discussions that we've had, that the benefits really outweigh the risks, but it's also important to be acutely aware of which type of patient you're putting on the medication, so that those that are predisposed to the conditions that we've actually discussed are not put on the medicine, but even if you decide to, then they are monitored quite closely. Next slide. Okay, so I just wanted to mention that as Lignum Vitae Health, we do have the male androgen, and you heard from Dr. Philomena that there are female androgen formulations that are there. If you're to use this, probably at 10% of the dose as mentioned, but it is definitely available. And you can be able to do it. Next slide, please. Yeah, it's available. So thanks again for listening to us. We are feeling absolutely privileged to have had this discussion. We do hope that we get to a point where we provide the women within the country some form of protection and assistance, especially those who undergo severe post-menopausal, perimenopausal symptoms to such an extent that it disrupts their quality of life. We have heard about some really horror stories about what the women of the country are going through, including even osteopenic fractures. But without there being consideration of inclusion of estrogen in their management. So thanks again. Back to you, Dr. Muchiri.
Thank you, Dr. Moses and Dr. Owende, for this was quite comprehensive. I had warned everyone that it's usually very difficult to have this chat in about an hour. As I hand it back to Dr. Kireki and the COGS team, would like to just hear what you have learned. If you have learned something new today, there's a Mentimeter code on the screen on the left. If you just answer that you've definitely learned something, or not really, I knew all that. I probably should have put another one and said what a waste of time, but hopefully it hasn't been a waste of time for anyone. And then I'll hand that back to Dr. Kireki. Thank you very much. Maybe if Dr. Kireki is not available, Dr. Owende, would you like to take us through the...
Yes, Dr. Kireki, if he's not available, then we could go through the questions on the chat box. Are you getting any responses for the Mentimeter on today's session?
Very good. Let me stop this now.
Okay. Yes. So let's have the next 10 minutes, then we can close and address some of these questions. The first one is to you, Dr. Muchiri, is what is your take on AMH in regards to menopause, and what does it mean when a young woman in her late 20s has a low AMH and still gets regular cycles? And secondly, to Dr. Alobo, what are the effects of body creams, pre and post gel application, sweating? What is the price? We're being requested for the slides. I think that is easy to share with the COGS team. And then that Mentimeter, Dr. Muchiri, takes them back to the first question. Maybe you could just clarify as we wait for the next set of questions. So please, let's respond to those there as we wait for the participants to ask more questions.
Yes, I think it's loading. Yeah, it's loading the question now. I'll try and share this for you guys so you can see. I thought by now I have mastered all these tech things, but obviously not. Okay, so you should be seeing the Mentimeter screen and the answers will be there. Yes, participants can now see the application. The question is there. Question on AMH. AMH has not yet, and I'm hoping it will be soon, be validated among the hormone tests that are in use for menopause and menopausal symptoms. There is a paper that's due to come, if it hasn't come out yet, that's looking to tell us at what level will the AMH be correlating with the FSH, because they don't necessarily correlate, if that makes sense. The FSH starts to rise higher and faster than the AMH changes. But there's some good piece of work that's coming out of, I believe, the UK and somewhere in the north, Professor Nick someone. They have looked at this AMH question and will be having an answer, but I hope it can be used. I think it's valuable, at least to give a prediction, or at least to say, yes, we are headed towards menopause, and what that means for us. So what does it mean for a lady who's got a low ovarian reserve but still having regular periods? The AMH does not, like I've mentioned, correlate with the periods. So you can continue to have very regular periods even with an AMH that's reading 0.1. The AMH is looking at the ovarian reserve that's left in the ovary. So as long as there's something that's being produced by the ovary, the lady will still continue to have a period. So it can be, yes, very low, 1 or 2, and they continue to have very regular periods. I think that was my question. Was there another one?
Yes. No. I think you've addressed it well. And just to add onto it, something that we didn't mention, and there's the concept of ideal window of opportunity for initiating MHT. And generally, that is between 50 and 60. So if the symptoms are severe and the woman has not been on MHT for up to the age of 60, then after 60 years, you might want to consider other treatment options and not MHT. And then for women who are above 40 and present with what we think are menopausal symptoms, you do not need to subject them to FSH testing or LH or other hormone testing that generally we would do for younger women below 40. I know the time did not allow us to discuss premature ovarian insufficiency, but probably in future we'll be able to discuss this. So Dr. Alobo, you have a question on the how the cream interacts with body creams in terms of pre and post gel application. Does sweating affect the efficacy, and what is the price of the gel?
Yeah, so this has been looked at, and it's a common question that it's important you apply on a clean, dry skin, inner side of the arm, and then let it fully absorb to an extent that it actually dries. And it's usually dry between 3 to 5 minutes. After that, you can apply your lotion. But my own advice will be to try and now do not apply lotion at that particular area. But if you have got particularly dry skin, then you can wait for a little bit longer, maybe 30 minutes to 1 hour before you actually apply. The good thing about it is that it is actually absorbed and sits in the epidermis dermis, and then it is released, actually dermis, and then it is released into the bloodstream at a constant rate of approximately 10% at any instance. And it does not necessarily, just sit on top of the epidermis. So again, things like sweating, therefore, should technically not affect the pharmacokinetics and pharmacodynamics of the drug. But again, as I said, once you, so for you to get a little bit of confidence around this is that for you to get to constant stable serum estradiol from this particular intervention, you need approximately 3 days to get there. And even if the patient was to miss a single dose, let's say 1 day, the disruption is usually not evident until, maybe they miss 2 or so doses. So again, we are not saying that patients should miss doses, but we are also saying that they should not apply a double dose in the next in the next one. What is the Price,
price?
Tanya, I'll allow you to put in
Yes. Chat
or
box. Yes,
mention something. Yeah,
she has posted.
Oh, she has. Okay, brilliant. Thank you.
Thanks, Moses. Yes, the price is 3,300, but we are very excited to have the transdermal formulation. And it's also important to note to my colleagues here that fortunately now we have a compounding pharmacy in Nairobi that also does the extemporaneous formulations. So just in case you did not know, so you're able to give your prescription and they can work on it and give you the desired dosing and formulations. So that's also available. So the next set of questions, then we can close. There's a question on the best alternative to vasomotor symptoms in a patient who is contraindicated to take MHT. This is a very good question. I think I'll take that. And then, is there any need for liver assessment, liver function assessment with those on Tibolon? And is there any preliminary tests before starting the HRT? I think this the last question we were able to answer it earlier, but the first one on vasomotor, very interesting, the best alternative. Let me just look at the work that is going on, is showing very good results with oxybutynin where it is not contraindicated. Other than MHT, your next best bet is with oxybutynin. The dosing will be at 2.5 milligrams BD or 5 milligrams BD if tolerated. Otherwise, you can also consider escitalopram. I've had some patients respond very well to escitalopram. And then there's also a group of women who also respond very well to just giving them Stilnox at night. You give it for a certain duration and then give them a drug holiday because there's a risk of there's a risk of the word escapes me. I think probably because of that age. But it's important to give it for a period of time and then you stop and then you can start again. So the next question, Dr. Muchiri, maybe you could just take it. I think I don't see any more questions on the chat box. But are there any preliminary tests before that? No, the one on liver functions. Do you need to do regular liver functions while taking Tibolon?
Not regularly, but I do a full profile. By full profile, I mean liver, kidneys, look at the bones, calcium, vitamin D, a full set of bloods before we start, because there are some patients who would qualify in terms of on paper, but then you look at their liver or kidneys and you're just not too happy with whatever they are showing, and mammograms and all that stuff. Now, if they're abnormal liver functions, we tend to look at maybe 1.5 times the elevations. Anything beyond that, I wouldn't be happy to start a lot of the hormonal related medicines, especially the oral ones. You can use transdermal, you can use the vaginal ones. And if the patient presents with any symptoms that sound like they're liver related, and that could be anything from their pale stools, itching on the skin, yellowing of eyes, all that stuff, then definitely do some liver functions. The follow-up is important. Maybe we should mention that as we go along. I don't think myself or Dr. Owende has addressed. When we start HRT, you don't start the HRT and send off the woman to nothingness and to deal with her life. We generally will see them every 3 months, at least for the first 6 to 12 months. And then we can spread out the consultations as soon as they're stable. The reason for that is things happen within the 3 months that you may want to revisit, things including the liver functions and kidney functions. But you don't need to test if there's no reason for you to keep testing. And this is the same, except for the studies that are being currently conducted, especially for Veoza, the phenolizethans, because that's been raised as part of the risk that we are assessing in terms of efficacy and whether we can use it or not in Veoza. So those patients do get liver function tests in study settings, but not on the outside. I've not had to do liver function tests for patients who've used Tibolon. That said, because of the side effects, a lot of our patients are on estrogen-progesterone combinations rather than tibolone as treatment. I hope that covers that.
Yes, I think very correctly answered. Just to add on to the issue of tibolone, usually when the symptoms subside, you want to reduce the dose. If you're starting at a dose of 2.5, and it's a very easy tablet to break, you could reduce the dose to 1.5, given once a day after the symptoms subside. So that really would also help reduce the risk of having any effects in the liver. But well answered, Dr. Muchiri. So the last question, then I think we can close, is on mammography. How often should you subject your clients on MHT for mammography?
Would you like me to take that?
Yes, please.
Okay. Mammography is not increased by virtue of someone being on HRT. I'm trying to see if that makes sense. So whatever schedules that you've got for breast cancer screening, and I say this because there's different there's different schedules dependent on the patient. So for example, patients who have a family history of breast cancer get more frequent interventions and screenings than normal populations. So the fact that you have put them on HRT does not mean that then you are going to be doing mammograms, sort of every 6 months or so. All patients, I always advise that they should be able to do their own breast screening because they will be the first people to pick up lumps themselves and their partners. I now teach the men also how to examine the breasts of the ladies rather than just, sort of use them as they do. So yeah, an annual mammogram should suffice when there's no risk. You should be able to pick up something that time. But remember, the people who have got risk factors in their families, then you want to keep a closer eye on them, test for BRCA genes, things like those. Yeah.
Thank you very much. And we now have our cancer guidelines from the Ministry of Health. I think you could also refer to the frequency of mammography. Having mentioned the issues on sexual function, I thought we'd have a lot of questions regarding that. But just remember, when you discuss sexual function with couples in menopause or perimenopause, remember to always also get their partners involved, because their partners tend to see the urologist. They are treated with Viagra or similar medication, and then the woman is suffering in pain. No one is addressing the dryness and the pain. So always remember, when they come with these symptoms, specifically ask about sexual function, and also let them bring their partners along for treatment. I think I've just seen a message from Dr. Kireki that he had to step out and has asked Dr. Gwako to stand in for him. I will be handing over to Dr. Gwako. Dr. Gwako, over to you.
Thank you, Dr. Owende. I'm not Cox, but yeah, Dr. Kireki stepped out. He had an emergency. So just to thank you, the whole team, Dr. Muchiri, Dr. Owende, Dr. Alobo, for a very, very comprehensive presentation on menopause. We started, I think, with a very comprehensive introduction, practical aspects of menopause management, myths and facts. We looked at the treatment, everything treatment and follow-up, and Dr. Alobo has also taken us through the studies, the evidence, and the drugs that are available, including the estrogel and androgel creams, and the audience also for attending and the questions. So I don't know, Dorcus, Dr. Muchiri, Dr. Owende, Alobo, if you have any closing remarks, can start with Dr. Muchiri.
Thank you, Dr. Gwako. I think for me, the excitement, since I know how long this has taken and the fact that we are looking forward to even better things coming into the country, I'm really excited to have seen the gel. In fact, I think I must have done a little dance because it means there's so many other women who would not have qualified for oral. So we are really grateful, Dr. Moses and your team, for having managed to bring this through into the country. And also to see that we've gotten nearly 97, 98 participants onto this platform on an evening. On a Thursday. I am really, really appreciative of the fact that people are making time to find this information and to ask questions. A lot of people do come into my inbox, and I'm happy to answer any sort of questions, even with your own patients and management. So asanteni sana for having me.
Thank you, Dr. Muchiri. Dr. Owende, closing remarks.
Thank you very much. I'd like to thank COGS for organizing this session. I'm also excited to see the transdermal formulation in our market. I know it's undergone very rigorous research before it was registered in Kenya, and now that it is here, women are benefiting already from that formulation. I'd like to inform you that women are on HRT anyway. Some are buying them over the counter. It's unfortunate, but let's guide them on use of the right HRT, the dosing and the route. Let's educate the women on the expected outcomes and follow up, and remember to reassess periodically and adjust therapy. Thank you very much, LVH, Tanya, and Dr. Alobo. Thank you very much. And again, my colleague, Dr. Muchiri, for giving us the tone, setting the tone for this webinar tonight. Thank you.
Thank you so much, Dr. Owende. And now the webinar sponsors, Dr. Alobo, closing remarks.
Thank you so much. So for us, we only managed to say a few things in this particular, time that we got available with the COGS. We do have our medical representatives in the field. We would like, and we are looking forward to get feedback from, the various different practitioners and what they're hearing from their patients, so that we can also improve our learning in terms of what we can put together in partnership with COGS for the sake of our patients. At the same time, we as a group, LVH, we are all about women's health. We do value the partnership that we've had with COGS, and definitely looking forward to having more and more of this. We have shown you our gels, but we do have many other products that we can discuss about. So there's an email on the slide. So for any adverse events or for any medical information that you may require, whether it's a clinical paper or any related request, you could, related to the products that we've discussed today, you could send an email to medical@lignumvitaehealth.com. And if it's an adverse event, we'll definitely be able to record it, have a look at it, understand it a little bit more, and then, of course, also report it to local authorities like PPB. But at the same time, if you want us to discuss any other medical information around what we've discussed today, we will be more than happy to dig out that particular clinical paper for you. So thanks again, COGS, for the partnership.
Thank you, Dr. Alobo. And at this point, I think we'll call it a night. Thanks, everybody, for attending. Keep checking your email inboxes for any other CMEs that are coming up. Do have a great evening.
Thank you.